Dr. Marik, welcome to the show.
Thank you, Mikhail. It's a pleasure to be here.
We're really delighted and honored to have you on the show. I was speaking with Anish earlier. You're you're among the most decorated physicians we've had on the show. We've had decorated physicians on the show. You're among the top here, but you're also among the most controversial ones. So your double product of controversy with times decoration is really sky high, and we want to talk about this, but you're a household name now. I mean, I get patients who call me randomly and said, I'd like to join your practice, but do you use the FLCCC or the Marik protocol or whatnot? you know, and and we'll talk about that. But I'm curious. I know that you're from South Africa, and I wanted to get a little bit of your background when you came here. I was looking through your CV and I saw that there were a lot of cardiology related papers that you wrote early in your career. Were you inclined to go
Yeah,
into cardiology at some point?
yeah. So my plan was to do cardiology, believe it or not, and then I did a rotation in the ICU, and that kind of changed it. But actually, in South Africa, when I was there, it was still, divided.
Mm-hmm.
So I worked in a white hospital and a black hospital. So most of the patients in the white hospital had coronary artery disease. So a lot of cardiology. And then in the black hospitals, an enormous amount of cardiomyopathies, possibly, alcoholic and other. So, cardiology, and then obviously rheumatic heart disease. We saw an enormous amount of, active rheumatic disease, active carditis, and then obviously valvular disease. So, I saw a lot of cardiology. So I was going to do it, but then I kind of fell in love with ICU.
All right. Did you know John Barlow? Did you rub elbow with John Barlow?
Actually, I knew John Paulo quite well. Actually, I was an intern in his ward, and I'll tell you a funny story if I can tell it.
Sure.
So, the ward, Johannesburg Hospital, overlooked the Johannesburg Zoo. So he's a very funny guy, and he's listening to the heart, and then he says, "Hey, do you know what I just noticed? That elephant there just had a big crap."
He is, he's. Most people here, I think, will know of among South African physicians, cardiologists or cardiac doctors. They know Christian Barnard, but John Barlow was really a remarkable clinician, and and South Africa has produced really just absolutely terrific in that period. Between the 1950s and 1980s, absolutely terrific
Yeah, I
clinicians.
mean, he could do with his ears what, echocardiography could do. I mean, it was
Hmm.
really an astonishing thing to watch. I mean, he'd listen to the heart and he'd tell you what the aortic gradient was.
Right.
um,
When did you come to the United States? After did you complete all your training in
yeah,
South
so
Africa?
my course was kind of circuitous. I was, I did my medical school, then I did my internal medicine. I actually spent 2 years in the army, which was compulsory then. I worked for a while at Baragwanath Hospital as an attending,
Hmm.
which is a truly interesting hospital. It's a 5,000 bed hospital, usually with an occupancy of about 6,000. There were more patients in the hospital than beds. Um,
Right.
and it was such a big hospital that, if we were in the ICU and we had to go do a consult in OBGYN, we'd get in a car and we'd drive there. It was such a big hospital.
Right. That's amazing. That's
Uh,
amazing.
then, yeah, then I decided, I thought academic potential in South Africa was somewhat limited. So then I went to Canada, did a critical care fellowship in London, Ontario, and then I was offered a position in the US, and I've been here ever since.
Okay. And your career has been absolutely stellar. From the get go. I mean, I'm looking at your resume. I mean, it's really unbelievable, and you've had, as I mentioned at the beginning, a very illustrious career. You still do. on the board of medical journals. You've published books on critical care, um, and but you've always been, I think, for a long time, willing to take positions. Or when did you start being a little controversial? Is it the vitamin C, or even before the vitamin C, there was people who
You
talked
know what?
about the
I
pulmonary.
think it's being a South African is that we were kind of taught to think out of the box.
Mm-hmm.
We were told to think and don't be a follower, be a thinker, and think of creative ways. So I've always challenged conventional wisdom, and then the more and more that I've followed medicine, that I questioned what we do, and I think that's not a bad thing. I think science grows, it develops, it's self-correcting, and I think one has to challenge conventional wisdom. I think, and that's part of my upbringing as a South African. I think because we were taught, to think.
Mm-hmm.
Whereas I think the students today and the medical students are just given stuff and they regurgitate it and they don't use their brain. I think the brain is the most underutilized organ because they're not taught to think. And especially now, patients come into our hospital, they go through the diagnostic donut, and then they ask the patient, what's the problem with you? Whereas we were first focused on, clinical exam and clinical science. I mean, I had a professor, these people are so in my brain who would walk into the ward and smell and say, that man's got typhoid. Or, they could listen to the lung and say, he's got a pericardial effusion. I mean, their clinical skills were just so astute.
Mm-hmm.
And I think that, clinical acumen has gone away because we just, we don't speak to patients, we don't examine patients, we do too many tests.
Right. No, I think that's quite clear, and we want to talk about this. We want to talk about um, the importance of the clinical experience of the physician and the doctor, but also the objective scientific standards of knowledge that we've come to get used to, and to what extent they can be in conflict with one physician's personal clinical experience and that sort of thing. Now, of course, right now you're most famous for this protocol that you've developed with your colleagues early on in the pandemic to try to provide treatment. Again, thinking a little bit outside the box. When the CDC and the FDA said there's not much to do for COVID-19, you developed some protocols, and some of them have become controversial. Um, I know, just for the audience, we know it's been in the news that there's been kind of a legal action that you're involved in right now. We don't want to talk about this. It's still fresh and whatnot, but we want to talk more broadly and more generally about the position that you and your colleagues have taken for a certain treatment protocol that maybe the majority of the established, the medical establishment keeps saying, doesn't work or has no
Yeah.
validity and whatnot. And how do we parse that out? We had on the show a couple of weeks ago a gentleman, James Heathers, who he and his colleagues had gone through some of the ivermectin data, not the clinical trials you were involved in, but some of the clinical trials that were that took place during the pandemic, and discovered that many of them were had big problems in them and so forth, and that sort of gave ammunition to the people who sort of were contradicting you to say, aha, now we know for sure that we were right. So what's your view on these things? You even before COVID, you were championing, and you continue to champion certain treatments, certain treatment protocols involving intravenous vitamin C for the treatment of sepsis, and you're quite confident, and you're not the only one, because there are people who follow you and who share your experience. And but it tends to be a minority. And then clinical trials are conducted. They show that they're not as successful as perhaps you would wish them to be, and that sort of thing. How do you resolve this tension?
Yeah, so I think, uh, any intervention has to have a basic biological premise. So, it's just not like you suck something out of thin air. There must be some kind of biological reason to do it. And what you may or may not know is that humans and guinea pigs are the only species on this planet that don't make vitamin C. So we don't make vitamin C. And, when an animal is stressed, as part of the stress response, it releases vitamin C. Vitamin C is a fundamental part of the stress response. Humans have lost the ability to make vitamin C, although during stress, they do release some from the adrenal gland. Um, what's interesting is if you look at the stress response, so there are some fish who don't make vitamin C. And if you stress the fish, the vitamin C producers make significantly less cortisol than those who don't make vitamin C. So vitamin C is part of the stress response and does an enormous amount of really important biological properties. So it does make sense that when a human is stressed, to give vitamin C. So, I mean, if you were a goat or a horse or whatever, and you were stressed, your vitamin C levels would go up and your stress response in terms of cortisol would be attenuated. So it is part of the normal stress response. Humans, for whatever reason, evolutionary, have a fatal mutation in the rate limiting enzyme. So that's one of the premises. And obviously, what we know is that sick and stressed people have very low vitamin C levels, and that the severity of illness and mortality is proportional to your vitamin C level. So then it just makes sense that if you're stressed and sick or whatever, maybe you should take vitamin C. Mm-hmm. So that's how this whole thing came about.
Right.
And the way it happened in our unit or with me is I had a patient who was dying of sepsis. There was no question. I think any clinician knows when you have a really sick patient in front of them, they're dying. I mean, the patient was in multi-system organ failure, renal failure, respiratory failure on 3 presses, had cholecystitis with overwhelming septicemia. She was dying. She was getting maximum therapy. So, much like in COVID, when a patient's dying, you say, you know what, let me try something. You're not just going to sit back and do nothing. So I had read about vitamin C given intravenously from Dr. Fowler. So I thought, why not? What have I got to lose? So I said, okay, let's give her steroids and vitamin C. And, this was like 4 or 5 in the afternoon. I did not expect that she would be alive the next day when I came back to work. And lo and behold, when I came back, the woman was off presses. She was on 3 presses when I left. She was off presses. And within about 3 or 4 hours, she was extubated. And her kidney function improved. And she left the ICU like 3 days later.
But the use of hydrocortisone, of course, complicates that, correct? Because of course there's this idea that when you're refractory to pressors, steroids are something that's part of the reason that refractoriness relates to a lack of your inability to produce the steroids that you need. Yeah. And when you have that, then you're refractory. So I mean that's always been the criticism of that protocol, correct? That hydrocortisone may complicate.
Let's start with the personal experience. Actually, I'd like to.
So I'll come back to that because it's a good question, and it has implications with COVID. I think many patients who are really sick, you need multiple drugs which work in multiple ways to act on different biological pathways. I mean, most chemotherapy, you don't use one drug, you use 3 or 4. So, I mean, it is a good question, and we added thiamine. But what we did actually is we did it in the reverse way. So, we treated a few patients and we said, wow, what's going on? And we treated more patients. So we developed the series. But then afterwards, we actually went to the lab. So we did in the reverse direction. So ODU is a few miles from my medical school, and there's a vascular biologist there who was interested in vascular biology. So they took vascular endothelium, exposed it to endotoxin. They measured viability of the endothelium and exposed it to vitamin C, steroid, and a combination, and showed actually synergy between the two, both histologically and looking at a whole bunch of biochemical pathways. So obviously it does complicate the question, but you know what? They seem to work together. And in fact, there are biological reasons for that to happen, is that vitamin C actually increases expression of the glucocorticoid receptor, and vitamin C actually prevents oxidation of the receptor. So that they seem to be biologically interaction between the two. So we think, now obviously it's a moving target. Now, one of the problems with the randomized trials, as you know, is that we become fixated with randomized controlled trials. Randomized controlled trials very rarely replicate real world practice, just because there's so many inclusion and exclusion criteria. And in critical care, you have to get informed consent, and that creates an enormous delay. So when we were treating people would come into the ICU, we treat them there and then. And we then even moved it to the emergency room. We'd start the first dose of antibiotic, they get vitamin C. If you have a look at the vitamin study out of Australia, which everyone put a dampen on, it was at least 18 hours. And we think it was probably even longer before they got their first dose. We don't know because they didn't actually record it. We know that from ICU admission to the first dose was 18 hours. Now, imagine if that was an antibiotic or that was a pressor. That would be an absurdity. So there was an enormous delay. And then there were other factors. Many of these were surgical patients, not medical patients. Ours were all pure medical patients. So I think there were a lot of confounders. But what was interesting is there was recently a paper from, I think it was China, where they randomized patients within 1.7 hours. The mortality difference was spectacular. So I think, there are a lot of confounding factors, in the studies. And even if you look at in critical care medicine this month, there are actually 2 systematic reviews of vitamin C. And while there was a trend towards a mortality reduction, so all cases, so these are all the studies, even those with long enrollment time, there was a small trend towards mortality reduction, but there was a significant reduction in the time on vasopressors and a significant quicker improvement in the SOFA score, statistically significant. So even though all these other studies people called negative actually had some biological effect that would be somewhat clinically useful. They were on pressors less and they got better quicker. So
right. Now it's I want to go back to the first case that you described, this woman who was sort of where you immediately you had a direct sense that the intervention made an effect. I think that's rare in medicine, and I assume that even in critical care, with your protocol, it's still not right. It's not like people just immediately their hemodynamics change immediately.
Yeah.
Right. So you give a treatment, and people in general from any illness, no illness is 100% has 100% mortality or 0% mortality. Right. These severe illness, it's going to be in between. So it's hard to. I mean, to what extent do you still feel in your clinical experience, forget randomized controlled trials and whatnot, in your clinical experience, when you give the treatment that you give, to what extent do you still feel that it makes a difference as opposed to, one of the many things that we do in the in the course of medicine, and we can't really tell for sure.
Yeah. So, I mean, it's something you see at the bedside, as a physician, you see something which works, it doesn't work. You give dobutamine and the cardiac output goes up. So we actually, when we give it and we don't give it, you can actually see a difference. And the best, nurses know best. The nurses are at the bedside. The nurses would tell me, hey, you know what? These patients get off presses a lot quicker. These patients get extubated a lot quicker. We're not doing as much CVVH as we used to. So the nurses could perceive that there was a change in the course of sepsis with this intervention. And for me, that says everything. If the nurses know best, and if they're telling me, hey, whatever you're doing is working, these patients seem to be getting better quicker, getting weaned off presses quicker, they're off the ICU, they're not having complications, it works. It's doing something.
Right.
And you don't need a randomized controlled trial. It's become the absolute arbiter of everything. You need a randomized controlled trial. And as a clinician, you do something, you see a benefit. And
is it possible to be fooled as a clinician at the bedside? Meaning a lot of times, I've when you give epinephrine to a patient and you watch the heart rate and the blood pressure go up, that's something that reliably happens on every single person you give epinephrine to, correct? Dobutamine, milrinone, and cardiac output is something similar when we monitor these. You killed the Swan-Ganz catheter back in the day when we had the Swan-Ganz catheter in the ICU. You could watch that happen, and so there's a gradation, right, in terms of what we're talking about there, and then what you're talking about when it comes to whether it be COVID, the early treatment of COVID in the outpatient setting, for instance, right? There you get a sense that there's a higher chance that clinicians may be fooled by what's happening to patients. This idea that you feel like you're doing something, the patients are getting better regardless. Am I making sense? Meaning you're absolutely right, and I've written about this multiple times. There's lots and lots of there's lots of historical examples that are pretty terrible in terms of us demanding randomized control trials. I've written about congenital diaphragmatic hernias and Ecmo, right? That's a classic example of where we mandated RCTs and we didn't agree with what the experts were saying. Somebody like you at the bedside who was putting these kids on Ecmo and the kids were getting better, and somebody demanded an RCT. Thomas Starzl, when he said that anti-rejection drugs were superior to the conventional, to the base, to what was being used at the time. When tacrolimus came out, he said tacrolimus was better. I'm telling you, based on the observational data that I have, and no, the FDA mandated that he do an RCT with program. So it's not that I'm unaware of the fact that we may be in an era of random, as Thomas Starzl nicknamed it, randomized trialomania. I totally get that. But we can't ignore the fact that there are certain situations, and certainly immunology, sepsis and critical care, certainly, because and I say sepsis in critical care because there's so many different etiologies for why somebody is septic, right? You already mentioned the fact that surgical septic patients are very different than medical septic patients, right? Then you have the 85-year-old septic patient versus the 40-year-old septic patient. My goodness, exactly. the heterogeneity there is so great that generalizing that something will treat that vast heterogeneous population. There are places where I can see that clinicians may get fooled. And so the question is, how do you, Dr. Marik, guard against that?
Yeah, so I think one has to look at the totality of evidence. When you're in a courtroom and they're presenting the evidence, there's usually not a smoking gun. It's the totality of the evidence. So I think it's basic science, it's biological plausibility, it's case series, it's observational data, it's epidemiological data, it's randomized data. There's good data that's showing observational studies, large observational studies produce results very similar to randomized controlled trials. So I think one needs to look at the totality of the evidence.
Now, Dr. Marik, so I think there was enthusiasm for your protocol when you first published about it before the randomized control trials. Is that correct? That the community was, I mean, at least there were some critical care people around the country, maybe around the world, I think, that thought, hey, this is a good idea, and started using it. Did they not get the same sense, or do some of them, or what's, how come, if that's the case, and if people could get, people who are experienced could have the same experience that you say you have with this protocol, why would you would think that people would dismiss a negative randomized control trial if the clinical evidence is superior?
So patient experience, I think, is really important, and we get patients who tell us, I was really feeling sick, I was feeling bad fever, malaise. I took the ivermectin. Within 24, 48 hours, I was a different person. So that's the first point. Secondly, and people aren't going to like what I'm going to say, that there are financial incentives for randomized controlled trials with cheap repurposed drugs to fail. So if you look at this paper in JAMA, which came out of Brazil, it was a profoundly flawed study. Firstly, they enrolled healthy people.
Again, is this a vitamin C paper, or is it
this is a ivermectin
paper? Okay, right.
So there's no question that the studies that fail get published in high impact journals. The studies that are impeccably done cannot be published. So there was a very good study done in Israel, impeccable, a randomized, double-blind, placebo-controlled, triple-blinded study with ivermectin in people with early symptomatic disease. And what they did, not only did they measure symptoms, they actually cultured the virus. They didn't just do PCR, they actually cultured the virus and showed that ivermectin significantly improved time to symptom resolution and significantly improved viral clearance as measured by culture.
Now,
that paper has not been published. You know why? You cannot get it published. But JAMA published a profoundly flawed study, that should never have been published. So,
but they do. I mean, I think maybe in all fairness, they do publish and they do study repurposed. I mean, dexamethasone was published. Fluvoxamine, and actually, I want to give credit to your group because you were among the first to talk about fluvoxamine as a treatment, and that's been published. So I don't know that we can say sort of broadly that all the repurposed medications are being squashed. It seems that some of them are being.
Yes, so that is true. I mean, the recovery study that they did, I don't think they were expecting the result that they found. I think they were not expecting a positive study, but because it was so highly powered that they found this benefit. It's very complicated. I think there are lots of complicating factors. So, the other thing is ivermectin so we're not ivermectin centric. As you know, our protocol has many drugs, and ivermectin is just one of them. But, there's been a lot of misinformation, as a dangerous horse deworming medicine. 3.7 billion doses have been given to human beings. If you go to the WHO's own pharmacovigilance website, it's probably one of the safest, if not safest, medications. Significantly more deaths from aspirin and Tylenol than from ivermectin.
Sure. But on ivermectin, how would you, you mentioned, for vitamin C, all the biological plausibility. where do you put ivermectin in that scale?
Oh, I mean, yes, the mechanisms of action have been really well determined. And this is what the Australians did. So, and it seems to act more on the host viral interaction rather than the virus. So there are in the nucleus, there's important channels which allow proteins to get into the nucleus through an important pathway. So that's how many transmitters get into the nucleus. So what ivermectin does is it binds to this important protein, preventing various proteins getting into the nucleus. What it does do is it blocks the nuclear protein of SARS-CoV-2 getting into the nucleus, which disrupts the cycle.
Right.
In addition, it binds to the protease. So there are a number of mechanisms by which it works. And also,
right, go ahead. Sorry.
And, you know, and data preceding COVID shows that it's a very good anti-inflammatory drug. It blocks NF-kappa B and production of pro-inflammatory cytokines, probably by preventing NF-kappa B getting into the nucleus via this important pathway. So there are really good animal data showing its anti-inflammatory properties.
Okay, and I haven't followed that closely, but I thought that at some point there was a question about the dose that to replicate the in vitro effects that
Yes.
you would need a much higher dose than what you
Yeah, so that's part of the false narrative. So that study was done in monkey kidney cells,
mm-hmm.
not in human cells. They actually repeated the experiment in human alveolar cells and found that the IC50 was significantly lower and within the range that you can achieve pharmacologically. So, you know, there were lots of reasons people found to try and disprove the utility of this drug.
Okay, fair enough. But so, would you say right now, to Anisha's point, you know, I've had patients who have received, in fact, very early on. I had a patient who got COVID in March of 2020, and I dealt with him over the phone, and he got better very quickly within 48 hours. I mean, there was sort of a dramatic improvement, even though he received no therapy. Yeah. So I keep thinking back to that person, and I'm thinking, you know, if I had given him X, Y, or Z, I might have, attribute his improvements to X, Y, and Z, when in fact people just get better. I mean, there's a natural healing process that is always operating in anybody. So where would you, the clinical trials, including the I forgot the one from Canada that was recently done, this I forgot the name, but when they tested fluvoxamine as well as ivermectin and hydroxychloroquine, it was negative for hydroxychloroquine and ivermectin, but it was positive for fluvoxamine. Where would you, do you still feel, or to what extent, I can see using it because it's so harmless, in a way, right? It has such a great side effect profile. But would you continue to say, I'm pretty sure it works, or how would you, what kind of proposition would you say when you describe the effectiveness of ivermectin? What's the strength of your endorsement of this treatment?
Yeah, so we don't recommend any single drug. So as I said, much like sepsis, there's no magic bullet. It's synergy with multiple drugs. So and there are many things people can do when they get COVID that doesn't involve ivermectin. Vitamin D. Why don't we talk about vitamin D? It's such a non-political compound that there's overwhelming data that people who are vitamin D deficient have an increased risk of death and of dying. And that if you supplement with vitamin D, and if you get your levels really above 50, you significantly protected from getting COVID. So that's a simple intervention. There's also the use of oropharyngeal sanitization with a whole bunch of compounds that actually are virucidal and kill the virus. Really good studies looking at intranasal sprays of povidone iodine for people with COVID, symptomatic people with COVID, that if you just use a virucidal spray in the nose, it rapidly clears the virus and decreases hospitalization with a cheap, effective intervention. You can look at melatonin. There's really good data that people on melatonin both have a decreased risk of getting COVID and a decreased risk of dying. So there are a whole host of things that you can do. Now, obviously, probably the most important data with ivermectin is the epidemiological data. So I'm not sure if you know this, but the state of Uttar Pradesh in India, 220 million people, they had a terrible outbreak of COVID. So the governor there said, okay, we're going to do a test, seek, and treat protocol with ivermectin. It abolished COVID. It abolished COVID. I mean, the temporal association is truly stunning. The same experiment was done in Mexico, the same experiment done in Chile. So there are multiple countries that have. Bangladesh, we heard 3 days ago, Bangladesh eliminated, although 20% of the population are vaccinated, they have eliminated SARS-CoV-2 with ivermectin.
That's because of the masks, though.
Oh, yes. Yes, everybody in Bangladesh is wearing a mask. So, you know what? So that's why I said it's the totality of the data. And, you have to, we're in the middle of a pandemic.
Yeah.
You have to say, you know what? You have to use the best data we have to do the best we can.
It's so interesting, Dr. Marik. I know the story of Uttar Pradesh because literally Joe Rogan must mention Uttar Pradesh on his podcast, on every single podcast. He pronounces it differently every time. It's Uttar Pradesh anyway. So it's the country of Uttar Pradesh. So there's no question, Uttar Pradesh has, instituted this ivermectin protocol, and cases came down a significant amount. But of course there are other states in India as well. India is a very populous country, and there are case curves that go up and down in states that maybe don't have as much ivermectin. And again, none of this is to say that I don't know. Again, luckily, thankfully, I have not been in your shoes, being on the front lines. I'm like in spitting distance of the front lines. I'm rarely ever the one who somebody's asking, what are you going to treat this critically ill COVID patient with, right? I'm like the cardiologist called because there's a troponin spill and somebody who's very ill. So I don't feel well in a great position to necessarily make a call on what exactly is the strong evidence for or against the use of not just ivermectin, but the entire MAT plus protocol, because luckily that's not my specialty, and hopefully I'm glad that there are folks like you and others who are facing those tough decisions. But I wonder, given the discourse that we've seen in the critical care community or in the wider medical community, is it reasonable for somebody to take a look at all the evidence, to hear what it is you and others have to say, but then to take a look at other possibilities and say, what, I don't think this protocol works. I'm going to stick with whatever conventional thing. Is that a reasonable? Do you have issues with your colleagues, say, who come on after rotating?
It depends what you say, what the standard is. So if the standard is remdesivir, which is the standard of care in this country, that remdesivir increases the risk of death by 4%. It increases your risk of renal failure by 20%. And what you may not know is the hospital gets a 20% bonus on the entire hospital bill if they prescribe remdesivir. Isn't that amazing? Yes, check the federal government registry.
Yeah.
So the government is giving you a bonus for using a drug which is toxic. So they used it for Ebola. If you have a look in the end of 2019, there was a randomized trial using remdesivir for Ebola. They had to stop it at the first interim analysis because of excess deaths and excess renal failure. So it becomes somewhat hypocritical when people are, saying ivermectin doesn't work and it costs pennies, where they're promoting remdesivir, which without question is a toxic drug which is expensive. So that what about the hypocrisy of that?
Again, I don't know the data nearly as well as you do on. I mean, I'll have to defer to you and others about this. But I guess the only question I'm asking is that is it well, number one, do you think that, I mean, you clearly care a tremendous amount about your patients. I saw a video. Anyway, I've seen multiple videos of you, and it's obvious how much you really care about your patients, their families, etc. But it can't be the case that, I mean, in my general impression of physicians in our community, that the large majority, I feel, who are on the front lines. I'm not talking about administrative MDs and C-suites who are removed from this. My general impression of somebody who's trying to take care of somebody who at the bedside is that they care a lot about these patients getting better. Why would they? I mean, I can't fathom that the vast majority of individual physicians are going to be making decisions on remdesivir based on the fact that the hospital is getting a 20%.
Yeah, no, I don't.
Bonus.
Yeah. So most people don't even know that.
Right.
That the 20%. They give it because it's part of the hospital protocol, and that's what they're recommending, and that's what the NIH recommends. So
but critical care physicians are not. I mean, are some of the most up to date on EBM and stuff. And so, do you think there's just like a? I mean, and this is totally happens.
So
why do you think that? Yeah, why do you think they're not?
COVID has turned the world upside down. There's no question of doubt. I think the world has gone mad. COVID has taken, what we cherished before, has taken it completely, turned it upside down. People are just too scared to go against the status quo. They're too scared to go against what the NIH says. So, on the, I think there are 25 members of the NIH Committee on Pharmaceuticals. 16 of them had direct financial ties with Gilead. 16, including the chairman of that committee. The problem is there is so much.
No, I'm certainly willing to believe that. I think there's no question about it. That there
is
the
protocol. I mean, we interviewed a. Did we interview? Well, no, I interviewed personally. I don't think we did it on the Accad Koka report. A physician early on in the COVID pandemic, who was who raised the alarm bells about how quickly we were intubating. How quickly patients with COVID were being intubated, because of, I remember the concern about, getting the airway controlled and not spreading it, and certainly, and then of course it was a nightmare once these patients got intubated because of the, dynamics of COVID, pneumonia and the ARDS or whatever that followed. And he was very against that. And he was basically run out of his ICU because he took a view that wasn't. So it's certainly the case that, is that the type of thing that you're noticing in your, like, are there a fair number of clinicians around you, where you've been practicing, that feel one way but are kind of forced to do one thing just because they don't want to deviate from protocol?
So, I can tell you, I get, speak with hundreds of physicians across the country, and many of them have a very similar philosophy to ours, but they don't want to talk about it publicly. And then there are physicians who just follow the line. This is the protocol: remdesivir, dexamethasone 6. I'm not doing anything else. And I think that's unfortunate because, as clinicians, we should think, we should challenge, we should, investigate, we should, pursue other options. I think just to be a follower, I think there's so much intimidation now. People are scared.
Right. But, I think what impressed me, and I need to remind myself of that periodically, is that what you said just earlier is that you're not a single horse sort of operation. early on, ivermectin was not even on the radar. You just said, this is how we do things. This is how we think we should approach critical care COVID. We should give vitamin C, hydroxycortisone, and certain other things, anticoagulants, whatnot. A different cocktail of treatments that you think are helpful. And then, with the madness of COVID, you became known as the ivermectin people, right? And perhaps, I don't know, I don't want to speak, but there may have been some people in the group that sort of opened yourselves to that sort of accusation by sort of saying ivermectin really, really works, and focusing attention on ivermectin. But I think it's important that at the end of the day, it cannot be adjudicated on the basis of objective outcomes, because that's impossible to do. Randomized control trials have limitations. You repeat them, it's going to be different circumstances and whatnot. At the end of the day, do I trust Paul Marik? Is he a person who cares about these patients? Is he very attentive? Does he stay up to date on the literature? Does he read? Is he smart? Is he, is he careless, or does he pay attention to side effects of new treatments or whatnot? And that's how it should be, right? At the end of the day, that's how it should be. Whereas we're so fixated on tabulating the outcomes and objectifying things that can't possibly be formalized in a way. And I assume that
Could I just add that,
it would give you a little bit more freedom also, that you may on one patient decide to drop the ivermectin and not give it and whatnot, and build
no two patients are the same.
Right.
Have you ever had two patients exactly the same?
Right.
And that's why I think you have to marry the science and the art and the being at the bedside. And it's your clinical judgment, and it's your understanding of physiology, and it's your goal to do the best for the patient, which is very broad and encompassing. It's just not medication. It's family support, it's nutrition, it's all kinds of things. It's fluid management. Mm-hmm. So I think you just have to have a reasonable approach to patient care. And I think you have to try and understand what you're doing and be thoughtful. I think you need a thoughtful physician at the bedside who's thinking about what he's doing.
That's exactly right. I mean, I was thinking about a colleague of mine in a practice I worked with. It was a large cardiology practice. He was an interventional cardiologist, and he was absolutely amazing. And his judgment on the spot, in tough situations, in a very sick patient with, complicated coronary anatomy, he could do things that no one else could do. And yet there's no way that you can translate what he could do into a clinical trial outcome basis, right? I imagine it's similar to a critical care doctor who has to make decisions about all kinds of different things, pay attention to details and be attentive to X, Y, and Z, and so forth. And there's no way that can transpire in the setting of a formalized clinical trial where everything has to be standardized.
Exactly.
And whatnot.
And what I think experience is important. Having, right. Like Tiger Woods said, is that the more I practice, the better I get. Is that, I think experience counts. Right. And that, I think I'm a much better clinician now than I was 10, 15 years ago, because you observe, you think, you ponder, and you say, gee whiz, what I used to do is really makes no sense. And so I think we grow. And I think that, medicine is a long journey, and I don't think you ever stop learning.
So do you think the rhetoric should be less about this, touting the value of an individual therapeutic or an individual medicine, even whether it's repurposed or whether it's a brand name, expensive ones, that we should always say, it's reasonable to consider using X in this setting, but for the particulars, it depends, right? It depends on what the circumstances are and what the situation is, and give freedom to people to.
Yeah, and for example, the dose. I mean, people say you give dexamethasone 6 milligrams. It makes no sense. I mean, it's like a patient in septic shock using the fixed dose of norepinephrine. It has to be dynamic, adjusted to your patient. Mm-hmm. It has to be. So, this fixed dexamethasone makes no sense. I think you have to look at your patient and you have to say, how am I going to best treat this patient with what medication I have?
Right. No, I agree, and it's very difficult to essentially survive in this environment where standardization in healthcare, in medicine, has become I mean, it's been a process for the last 30 years. In fact, ever since the word evidence-based medicine was invented, the purpose was to standardize, to standardize the way physicians practice, and
Yeah, I mean,
it's really wrong.
You're right, because otherwise you could have, you wouldn't need doctors. You could have computers and algorithms driving patients. So I think you still need the clinical acumen at the bedside. And I think the problem with all these protocolized medicine is it takes away the thought process of people actually having to think what to do.
Dr. Marik, if you were in charge, would you have a problem with clinicians deviating from the math protocol?
No, I think that, so the clinician must do what he thinks is best for his patient.
Yes,
I think that's the bottom line.
Yeah, no, I think it's, sorry, you're so correct. And I think the move that the place we've gone in the last 20 years, I mean, just the 20 years that I've been in medicine, you've been in much longer, is really, really a scary place where we are almost to the point of criminalizing certain physician thought in terms of, so, that Overton window has gotten so narrow in terms of what you can do that it's really, really scary. I think you're absolutely right. I mean, a clinician needs to decide based on the review of the data. Smart, thoughtful clinicians who care about their patients at the bedside need to decide what the best thing is for their patient. That may be the math protocol, that may be not the math protocol, that may be vitamin C, it may not be vitamin C. And we as physicians in that community need to support that variability, regardless of what our thoughts are. So hopefully you wouldn't cancel me because I would put a Swan-Ganz catheter in.
Sure. I think what you say is true. Let doctors be doctors and let them doctor at the bedside. And I don't tell doctors how to treat. Let them decide. I can give them the information. I can say, here, look, this is the data. But you decide. It's your patient. You must decide what you think is best for your patient.
Correct. And what it is that it speaks to the dangers of this environment that pre-exists COVID. Where the regulatory environment, the environment of third-party payments. I mean, I'm going to get on my soapbox here against insurance and third-party payments and whatnot. That really distorts because they start demanding, right? They start demanding objectivity and formalization and standardization because that's the only way they can operate. The only way an insurance company can operate is by asking, standardizing everything and demanding from the doctors whom they pay to standardize their practice, and therefore the doctors end up responding to that kind of thinking. Same thing with it doesn't matter if the insurance is a government insurance or private insurance. It's the same thinking, and it goes back even to, as far as I'm concerned, to even licensing of doctors, right? I mean, when you license doctors, you have medical boards that it's on the pretense that you can standardize a very personal relationship instead of trusting that good, honest physicians will be rewarded by patients, in the long run in a very natural way. And that will allow the best, and so that it wouldn't be, I'm going to Dr. Marik because he prescribes ivermectin, but I'm going to Dr. Marik because he's a great doctor, he's got great experience, and he can use his judgment on the spot with respect to my own circumstances. And so that's I'm gonna get off my soapbox. Any other thoughts? Any other question, Anish?
Yeah, I think the bottom line is I think doctors must be doctors. We shouldn't have the federal government. We shouldn't have regulatory boards. We shouldn't have hospitals telling doctors how to be doctors. We should let them. We should educate them. They should educate themselves, and they should do what they think is best for their patient. And I think that's the bottom line. And I think we need to get away from teaching medical students to be automatons where they don't think.
Amen. Anish, anything else before we?
I just wondered, is there anything, Dr. Marik, you'd like to comment on in terms of the issues in terms of what type of pressure is brought to bear by local communities or hospitals, anything that you feel you'd like to say?
Yeah, I mean,
it's your, you don't have to say anything, but
yeah. So
we feel for what you're going through. And
yeah, so I mean, we'll talk about ivermectin or hydroxychloroquine because that's become such an issue. And actually, if you look at the FDA's own regulations in terms of off-label drugs, the FDA encourages the use of off-label drugs, and they state that it's perfectly fine for clinicians to use off-label drugs based on their clinical judgment. But somehow using an off-label drug since COVID has become some kind of a bad thing. So, it just doesn't make sense. I think, every intervention should be judged on its own. It's an FDA approved drug. It's not an experimental drug. And if your clinician thinks it's useful, well, let him use it. You're a cardiologist. You give aspirin for atrial fibrillation, do you not? Sometimes, if you want to.
Sometimes if you want to, right? That's a good answer.
That's an off-label use.
Right.
Using amiodarone for atrial fibrillation.
Yeah.
Is an off-label use.
Yeah.
So we don't. So it's become completely bizarre. Most, 40% of drugs used in the hospital are used off-label, and acetylcysteine is used off-label. So the distinction between on-label and off-label is just so bizarre. But somehow COVID seems to have turned that upside down. I mean, we use Haldol in the ICU for delirium. It's like used every day. It's off-label. We just use it. We don't say, oh, it's off-label. We've got to get informed consent. We've got to fill in these forms. No, it's off-label, but it's an FDA-approved drug. You understand how the drug works. You know its mechanism of action. And you should be...
You know what this goes back to? This goes back to the FDA amendments in the 1970s that turned the FDA from being an agency primarily involved in making sure that the drugs prescribed were safe to also making sure the drugs prescribed or the therapies prescribed were efficacious. I think once that happened, it's been all downhill, because once you start going with this binary, up or down vote for a variety of different things, then I think we get into real big problems, and you end up in a place where we are now, where if you are not prescribing the efficacious, that thing that somebody has stamped, then you are bad, right? And that's not good. I think, and I think this this comes from the medical community. So I think our colleagues are need to be a lot more tolerant of a wide variety of different therapeutics, because everyone is going to read and have a different lived experience and come to things differently. And in terms of where we come with safety and do no harm, okay, fine. If there's a doctor that is running around giving lethal doses of of some medication that is definitely harmful, that is a whole different place that we as a physician community need to step up and keep the patient community safe. But yeah, you have a lot of as you're saying, I mean, many of the drugs that are given off label have been in use for a very long time and have a very well-defined safety profile, whether it be hydroxychloroquine or ivermectin or baby aspirin, amiodarone, etc. Like we know they all have toxicities, but we know their safety profile very well because they've been tried for years and years. And if a doctor thinks for some reason that, hey, this is going to work here, I don't know that we should be we should have these blinders on as we do. So,
and variety is the spice of life. That's just the way it is.
Right.
Well, Dr. Marik, you've been very courageous and throughout this pandemic, and you've been very thoughtful and among the first to sort of speak out with your group about doing something different and not having this herd mentality that is so harmful to physicians and ultimately to patients as well. We thank you very much, and we wish you the best.
Thanks, and it's been wonderful talking with you. Thank you, hey.
Thank you.
you.